Here's the agenda. I think we just had an EMIS breakout session prior to this, haven't we?
Agenda. You want me to have a look at this for the joined group?
Yeah, so should we give people a minute to join from the EMIS group?
Yeah. I will mention we have changed it around a little bit from last time. So we used to do the joint session first and then go into system one, then EMIS, but we did find that it was a bit difficult for anyone presenting something in both to be jumping from one to another if times didn't go exactly right. So from now on, we're going to do like we've done today, EMIS, then the joint, and then the system one.
Okay. Okay, should we make a start, Mark? I think you're first on. Is Mark on the call?
Not yet, I don't think. Oh, wait a second. No, not that I can see.
Give me another minute. Otherwise, we could start with Blaine. I suppose switch the first two around.
Yeah. Just me. Oh, I think Matt's joined us now.
I have.
Hi, Matt.
What a time for your machine to reboot. I was just waiting, and yeah, Team decided to play up. And I don't know why it does it either. For anyone else, it just seems to have a mind of its own. Yeah.
Hi, Mark. We're just going to make a start with yourself first.
Okay, no problem. So clinically wise, I don't think there's much to cover. There's not been many events since the last time we met. What we have done is we met with TPP a couple of times. So I've not got the same update for the EMIS guys at the moment, although we are trying. And we try to put together a set of master classes around some of the TPP functions that are there that we might not be either using or getting full advantage of. So we're looking at a list of 5. It's early days yet. We just started to work with TPP the last week or so to put those together, and then we'll be able to advertise those out for people to be able to come and see what's in there and what values out of them, and if there's any benefit in really taking those up at a practice level. Okay, so that's the first one. The second one is a shameless plug about Windows 10 machines that practices have still got, and if anyone's got any out there and have got any any way to persuade their users to surrender them to let us upgrade them, if you can do, please. Otherwise, we're going to get to a point where we're going to end up having to disconnect them, and then they won't be able to access any clinical systems, and they'll have to do quite a long trip to Apex House to be re-enabled. So if you've got those in your practices, please, as the guys contact you, please make those available so we can update. And then finally, the one that's quite a hot topic at the moment is AI. So AI seems to cool down a little bit on requests. And again, more from TPP than other sides. We've started to see a couple of TPP product releases, new features into their product as well, which are duplicating now some of the things that were out in the wider community by third parties. Again, if anyone's got any wish to pursue AI, there is an AI mailbox that I'll drop into the chat, and if you contact that, we'll get back to you. It is only a small team, myself and one other person, but we are trying to get around those to any queries. We're not installing or helping with implementing assistance of AI, but we will be there to signpost any documentation or relevant legislation that we need to follow. And I think that covers really. It's been hectic, but there's not an awful lot to say, unfortunately. I don't know if anyone's got any questions.
No.
No, there's nothing in the chat. Okay.
Okay, thanks, Mark.
Okay, cheers.
Moving on to Blaine. Are you there, Blaine?
Yeah, I'm here. Hi, Guy. Hello, everybody. Just to give you a quick IG update, which everybody, it's the highlight of these shows, I'm sure. So the first thing is Open Safely, which most of you should know about by now. But following the data provision notice from the Secretary of State, Open Safely was used for COVID-19 research that's been extended and opened up further. That data provision notice essentially means that GP practices have to provide access to that information. So there's a few things that you may need to do if you haven't done so already, which is to instruct your system supplier. I think it's just a checkbox confirming that you opt in to the sharing. The other thing that you need to do is update your privacy notice. I have sent out the wording before as part of the primary care comms and the data quality bulletin, but I'll pop a link in there as well, into the chat as well for you to find it. But if not, just give me a shout. The other things for you to be aware of with Open Safely is that the DPIA, so the Data Protection Impact Assessment, has been completed and signed off by the Data Protection Officer for these GP practices, or those GP practices that have Aaron as your Data Protection Officer. And so that's been signed off. And the only other thing you need to do is make sure that your ROPA, or your Information Asset Register, is also updated. These are things that NHS England have decided needs to be done by GP practices, even though it is an instruction that we have to comply with that data sharing. So that's the first thing. I've got a couple more things for everybody. The first one is I've put some freedom of information guidance on the extranet as well. I will also link through to that. It is worth a read, as we're getting a few more freedom of information requests, and it's just about how we handle them and what we're doing with them, and making sure that we're recording them and logging them correctly. The other one is a bit of a request slash ask slash complaint from Leeds Community Healthcare, LCH, who have been in touch with me a number of times over subject access requests, and where GP practices are releasing information of LCH. That's not the letters in the discharge and things like that. That's held within the GP records. That's all fine. It's when we're releasing information from their unit. So we're opening up their unit and sharing that with patients. Just a reminder that any subject access request should just look at your GP practice's unit and the GP record of that patient. Finally, 4 letters that everybody loves so much, DSPT, to the Data Security Protection Toolkit. That has been released again for this year, even though we've just finished last year. It's just a bit of a heads up for GP practices that this year it has increased in size somewhat, as kind of expected. It is mainly around GPIT and our IT infrastructure, things like backup, restores and stuff like that. So we're going to start looking into it. Just a heads up that there is a little bit more to do, but I'll be letting you know throughout the running for the next toolkit, and advising you as appropriate and giving you all of those resources that you need to do. So that's it from me. Happy to take some questions. Alexis.
Hi, Glenn. So the
Hi.
privacy notice for the Open Safety, does that affect PCNs as well? So do we have to update that section onto our privacy notice as a PCN, or is it just GP practices?
It technically is just GP practices, but more information on PCNs may not be necessarily a bad thing. Let's put it that way.
Okay, yeah, no, that's great. Thanks, Glenn.
And I think there's something from Liz in the chat. How are people opening up? Well, it's opening LCH systems, it's not necessarily that they're open up, it's when they're looking at the subject access request, they're looking at the full record of the patient, which will include information from other units. So it's just making sure that when we're checking our SARS, that is only the GP unit that we're looking at. And our practices data controllers, if info on practice systems, i.e. letters, yes, you are. So any information that is contained within that GP practice, that patient's GP record, including discharge letters and things like that, from other organisations, as long as that has been put onto their GP record, then yes, and you are the data controller of that and should be looking at whether that is released or not. It's when you start looking into other units. Do people own SAR? I think that was the H, which.
That was just me. Sorry, Blaine.
Oh,
just
sorry.
saying, if you use the SARS functionality in System 1, I think it allows you to filter only on your own data, doesn't it? It's got a drop down. I don't know if Andy or anybody's on the call to just clarify that, but I'm pretty sure there's a functionality that says, or Craig's on the call, your own data or something in the SARS functionality.
Yeah, we'd love to hear from a systems specialist.
Sorry, I missed the question.
The SARS functionality, Craig, in System 1, I don't know about EMIS, but it definitely allows you to filter just your own data, doesn't it?
Yes, it does. Yeah, you can filter out other things.
Yeah, it should stop you sharing LCH by mistake.
Yes, please. Super, thanks for that. I mean, they're really helpful. Thanks. I think that's it.
Okay, Blaine, thanks very much. Moving on, we've got Jane next on the agenda. PQI.
Hiya. My name's Jane Isherwood. I'm a BI analyst in the business intelligence team, focusing mainly on primary care and cancer. I'm here to talk about the PQI today. So that's the Practice Quality Improvement Dashboard. Includes about 120 national and local indicators, together with workforce and demographic data as well. Created it together with the primary care team to be like a one-stop shop for practices, PCN and primary care colleagues to try and see all the data in one place rather than having to jump into all the different various sources of the data. I'll just share my screen and bring it up. So I've dropped the link into the chat, but it's available in Teams. We're on the 25-26 version, so it's in this folder. It's a private team, so you need to, if you don't have access, if you're not in that team, then either drop me an email or click on the link, and if you don't have access, it'll give me a notification, then I can give you access. So there's various files in the folder, but the one we're talking about today is the PQI, and it looks like mine automatically opens up in Excel because that's the way I prefer it to, but it can also open up in Teams. So you start with the summary page really, and then there's a drop down box at the top, so you can choose the ICB, so the leads total, a practice, PCNs are further down the list, and then you can also do it by deprived leads and non-deprived leads, so you can just choose a practice. So it's quite big, so it can be a bit slow to load sometimes. So then it gives you some key information there. So the decile, the CQC rating, and then just some demographic sort of information to benchmark. Then it gives you a list of the highest and lowest indicators from the key indicators tab and the core contract only, and tells you it's based on ranks just to help improve quality really. It also has these little quick links, so if you wanted to quickly jump to workforce, you can jump there and the box up there takes you back to that summary page, so you can jump backwards and forwards between the different key areas. So the first one is key indicators. So these are the primary care seem to have decided these are the ones that we need to have greatest focus. So things like cervical screening, even though the data's not flowing, child IMS, flu vax, health checks for SMI and LD, and then QOF. So first we have a group name, the indicators, name of the thing, some clinical, which we've added fairly recently, some these are the names of the searches within the clinical systems. Then it gives you your current percentage or total, gives you an ICB total or average, national target if available, highest and lowest practice within the ICB leads, data sources, data period, and then a rank, and then a trend. So that's just usually based on the previous period, whether it's just going up or down, and then a little graph to sort of give you an indication of direction of travel. And all the pages are more or less run the same. If the practice as is in the top 10 practices, then it comes up, it should come up as blue. If you're in the lower 10, then it comes up as red. So it sort of draws your attention to the different indicators. On the next page, which is core contract, it has some different areas on here. So information technology, prevention, so vaccinations and more screening, health checks, health inequalities, incident reporting, and then dementia and advice and guidance numbers. And all the pages run, the columns are all the same. For historical trends, it's best to have a look at the graphs page, so you can see the sort of direction of travel and where you whether it's increasing or decreasing. Some of these indicators run like back to 1920, and like screening goes back to January 16, so quite a long period of data that's held within the report. Further down is some graphs for GPOP, and then some supporting searches as well. So the next tab there is GPOP. There's only graphs for the top section, but below there's the second section, which is the prescribing. That's only updated every quarter. And then the second section for MedZops, which is the it's linked to the CSR dashboard, if I could say it. And there's if you click that blue box there, it takes you to the full dashboard. This is just the high level figures, and then the activity bundle is in there as well. PCN, so the two IIF measures that are current for this year are in there. So the learning disabilities and cancer. Workforce is in there as well, and PCN workforce. For PCN workforce, you need to use this drop down box instead of the one that's on the summary page. Then it moves on to some access information, looking at walking activity, so A&E, out of hours, 111, etc., and sort of says whether it's higher than lower than the previous year. And then there's also patient experience in there and some more digital access, so whether patients have online access, NHS app, online consultations, CareNav, Pharmacy First, and 111 direct booking. And I think that's the main tabs. There is a bit of an instructions page there right at the beginning, and the updates page is, it shows you when the indicators have last been updated, so you can check there to see. But I do send a note out every Thursday, usually it is, to say what's been updated this week. So I do send that out to the whole team. I don't know if anybody's got any questions or want me to go in anything more detail, because that was a bit of a whistle-stop tour. Silence.
Okay, Jane, that was really informative. Thanks. If there's no more questions, should we move on to Kathy with health inequalities?
Hi, I'm Catherine McDonald, or Catherine McDonald from the Data Quality team. And myself and Lisa Batkin have been working on the Health Inequalities template or repository for around about 2 years. I'll let Lisa come in. Have we got Lisa?
Yeah,
Hiya.
hello. Good afternoon, everybody. Lisa Batkin, Public Health Previous of this parish. It's lovely to see you all again.
Okay, I'm just struggling with the internet connection at this minute. No. Okay, Lisa, do you want to take it away with this presentation? I'm actually struggling to get onto System 1 to do the demo as well. And this looks a bit big, doesn't it, the text?
Yeah, it's fine, Kathy. Let's see how far we go. I'll whiz through the slides. I'm having connection problems as well. That's why I sent them over to you. So let's see where we go. Do you want to go on to the next slide?
It's a bit better. That's better.
Yeah. So that these are our email addresses if needed, and we, like Kathy mentioned, we've got a health inequalities clinical repository that we've built in Leeds. Next slide, Kathy. So just a bit of context. So this health inequalities template, which we're now calling the repository, just due to the size of it, was first built when we had the pandemic. So if you remember when we had our clinically extremely vulnerable people, when the big arm came down telling everybody to stay indoors and shield and don't go out, and then we had all these people like ringing up general practice saying, oh, I can't get me shopping and I can't get me prescription and I can't do this, and what happens if I get sick and how do I get to the doctors? So we built a COVID welfare checklist template. If you can cast your mind back to that, and these have lots of questions on asking patients around like how they live the life, what kind of house they live, do they live on their own, do they need any additional help, and then we could link them in with the social prescribers and the R staff. So we built this welfare checklist to support general practice and wider primary care throughout the pandemic. And then once everything had settled down a little bit, we noticed that a lot of people, when we had a look at the COVID welfare checklist, we noticed that primary care was still actually using it to record social issues. And then being over in the council now, I got involved in the team about the Marmot City, and Leeds was starting to emerge as a Marmot City. And we recognised that primary care did want to play its part in health inequalities, but didn't really wanted to make it make sense. I didn't really know what their ask was. So we decided that we'd use a COVID welfare checklist and make it bigger to be able to record the social determinants of health, so we could really start to see about how people live their lives and align it with long-term conditions. And what's been really interesting is when we've looked at the read codes, nobody else in the country has done this. So this is really like pioneering work for Leeds. So yeah, it's been really long but really positive piece of work with Kathy. Thanks. Next slide, please, Kathy. So this, for people who don't know, this is lovely Hasantha. So he's a GP at Chapeltown Family Surgery, and he's been our beacon really, and our guiding light. So he's been our GP that's helped us design this. So you can see in a nutshell, this was, you know, we went to see Hasantha and said, if we're going to build a health inequalities template, Hasantha, what would help you in your practice as a jobbing GP, as he called himself, thinking about Marmot and the social determinants of health and everything you see when people walk through the door. And just a little snippet of his brain at the bottom here says, you know, after 20 years of working in the as a GP in a city practice, one thing is clear: people lead complicated lives and present with complex problems. And what they don't present with is a condition called a health inequality. They ask for help with the house they live in, or the trauma they've experienced growing up, or accessing the help they need because they don't speak English. And we want to help, but we don't know where to start. And I think that's really important. And I think we all recognise that in primary care. We do see it every day. So when we was thinking about building a template, we asked him what would help you. So we asked for making it make sense. Marmot is very nebulous. How can I make the Marmot principles make sense for me as a GP? Offer me a pathway with clear solutions that don't take a lot of time. And it was really, that was something that was really important to him. Build something that will change and grow as I become more confident in tackling health inequalities, and show me how I can work with other organisations. So a little bit of an ask, but we're always up for a challenge. So we got to work, didn't we, Kathy? So next slide, please. And one of the first things we did is that we have built these, you may have seen them, these PCN infographics. So we've built these, so every PCN has these PCN infographics. And these are just entry-level data sets for every primary care network, and they're embedded within the health inequality template. So we've built them around adults, and we've built them around children, and we've put the core 20+5 on every single one because we recognise its relevance. But then surrounding all that is data that makes every PCN slightly different from its neighbour or its surrounding other PCNs as well. So these are available for every PCN, and then you've got a little QR code. So if you're curious or you want to see for more information, you can have a look at that QR code, and it'll take you off to the Leeds Observatory, where there's a whole wealth of data. And this is just an example. So this is BHR PCN, and it just shows you, obviously working like with Jane, so that like Jane's head with the red, is a bit of a flag, really, to say that this is different from other PCNs. So it just shows you like the nuance of it all. And it's really interesting. And things are not as they first seen. So for example, things like common mental health issues and mental health, we know we've got data differences, and things don't always first appear as what they seem. So tread with caution with these, but they do give you like a good landscape of your PCN. The next slide, please. So after we built this template, we recognised there was no inclusion health tab. So we're working with Lucy Chiddick to build an inclusion health tab with that. So this is like kind of generated more work for us. So that is something that we are going to be addressing. Inclusion health is really ramping up apart, thinking about the 10-year plan and the neighbourhood health. So we're really thinking about how we can health inequalities and inclusion health, what that means for primary care. And there also wasn't a migrant health template. We had a Ukraine refugee template, but we didn't have a migrant health one. So we've built that as well to help practices when they're getting people, new registered patients coming through, they can use a migrant health template as well, because they can require different needs than our our people that are Indigenous people that live here as a new patient. Next slide, please, Kathy. So this is some really early feedback and analytics from the template. So we've extracted some data from November. We've had 1,355 newly added homes data recorded. Again, we don't think this has happened anywhere nationally. We've got 398 recorded patients living with damp and mould, and 658 recorded as inadequate housing. And this is the first time that we've used the clinical systems to align with housing. Anecdotal information is really positive practitioner feedback. General practitioners found the template practical and valuable. It's improved patient interaction. Clinicians report better documentation of social health factors and increased referrals to support services. So that is really early intel from a very soft launch that we've had with the Health Inequality Repository. Thank you, Kathy. Next slide. So all our tabs relate to the Marmot Principles. So we've embedded the Marmot Principles, which is social determinant health, a life course approach to all the things that all his principles. We embedded them into a medical model clinical system. So it's been a real labour of love really for Kathy and I. All the tabs have the same questions with the same read codes, and now after we built it, we asked people to use it, and then we got feedback, and there was a clinician saying we love it, but it's massive. So we've now got two. We've got one for children and we've got one for adults, and this has been allowed us to embed it into other templates as well. So it'll just help. So if someone's coming for a long-term condition or annual review, and they're telling you that they've got problems with the housing, it's got damp and mold or whatever, you can quickly recode that, and then it not only does the template allow you a place to recode issues, we also offer solutions as well. So we've also fixed that. One of the major things has been the housing tab. So I don't know if you know, but general practice doesn't need a letter for housing anymore. We fixed that, the lease care record. Housing can see that. So you don't, if a patient comes to you asking for a letter for housing, you do not have to, they don't need it anymore. But what we have done, we've put a patient summary on the housing tab that the admin team can print off and give to that patient if they're still demanding for that housing letter. So we've also put a housing referral pathway in as well. So if they're coming to you asking for help with the housing, we can dependent on the type of tenure that this patient has, there is a direct link to the right email for the right place as well. And we spoke, again, being over the council, I'll be able to trot over to the housing team and say, general practice will be emailing you more often, and if they do get it wrong, please don't bounce it back. Please help us by sending it to the right place. And they've been really useful and really helpful in helping us with that. So the housing tab has been really important for the use of this template. Thank you, Kathy. Next slide. So this is just some national relevance. We're going out speaking nationally, so we know Cardiff are using it now. We was on the national call yesterday, and Oxford are trialling it. So it is being picked up because we purposely built it as a wireframe so people can scrape off our local solutions, but still use the like the wireframe with it all with the read codes on. So so we're helping nationally now with this. So it'd be really good if Leeds used it a lot more. Just because we built it here, we want to be really proud of it. So that's what we're doing kind of nationally with it, and we built it obviously on both. I say I haven't. Kathy has built it both on both systems. Thank you, Kathy. Yeah, there's just some additional resources here. So Asantha's been out to Target, so there's a link here. So if you want to watch Asantha talk about the health inequality template, and then we've got some fairer, healthier primary care and Leeds, that a report that we published through the Institute of Health Equity that shows you all the work we've been doing around health inequalities in primary care. And yeah, so that's me. So I'll stop talking and hand you over to Kathy, and hopefully she can get you on the system and just quickly show you what the template looks like. Thank you, everybody.
Thank you, Lisa. I tried to get into a live practice, but I've been unable to, so we'll just have to do it a bit of a clunky way around. It's going rather slow. Got to cross my fingers that it doesn't crash, because it did like 5 minutes before we were talking. Sorry about this. I'll stop sharing just to see if it helps with it loading up, and then I'll share again. But while it's attempting to load, it can be found on the blue dot. So when you go into the blue dot, it's under H for health inequalities, and you click on that page, it takes you to the landing page where that video of Michael Marmot is as well, talking about the health inequalities and what a Marmot city is. And on that front page, you just click a link into children 0 to 18, and then there's an adult page. I don't think I'm going to be able to show you it. It's just still whizzing round. Hopefully, I may be able to come back to it at the end, if that's okay.
Okay, Kathy, let us know if you can come back to it.
Yeah, I'll keep trying.
So,
I think
any,
Amelia said she'd share. Sorry, Guy. Sorry, I'm just
All
looking at the
right,
chat.
okay.
Do you want me to try it? I've no idea. If
Yeah,
it'll work,
yeah.
but I'll have a go.
I don't know whether there's an issue with System 1 at the minute because mine's froze as well.
Oh, has it?
Yeah.
I couldn't get onto a practice at all. I tried to get, to get a test patient up rather than going through 3 templates on the system and showing the blue dot and everything. But yeah.
Is that showing?
yeah, we can see that, Amelia.
You have to tell me what I need to do, Kathy.
Okay, let me come over then. All right, okay. So so this is the adult template. So the overarching page there, you can see your links behind. So if you just click on age 18 to 25, Amelia, please. So we've got down the side, healthy standard of living for all, and this is on each page, and this is purely to stop the clicks, because we're using this as a repository, not as a template. When a patient comes in, we're not saying, right, you have to go and ask all these questions. It's just if they disclose things, you've got somewhere to record it, so we're capturing that information. We're getting those read codes in the background so we can create reports on the back of them. As you can see there, some of it's overcrowded in the house. Do they have bed bugs? Is there damp and mold in the house? What is the home status behind that home status? Is it rented? Is it sorry, mine's crashed now. Sorry, I have to come back to my screen. Right, okay. Your home status, do you rent from a private landlord? Do you rent from the council? Do you own your own home? There are, let's have a look. You just scroll down again, Amelia. Are there any issues at home? Any alcohol misuse, drug misuse, domestic violence, any imprisonment of a family member? Obviously, if you are talking about this, you might need to go to the safeguarding template as well. Do they have access to outdoor areas of the home? What are the relationships like with the neighbours? Have they got problems? Are they a victim of crime? So when patients have disclosed this sort of information before, we've never been able to do anything. It's just been a nod of the head and you're listening and accepting what the patient's saying. But now we've got some links where we can signpost the patients to if they are a victim of crime or a hate crime. And then on the other side, you've got, if you just bob to the top, please. You've got what relates around the 18 to 25 years. So is the work regular or uncertain? Are they on one of these temporary contracts? You've got the read code there for prison record. Again, patients don't have to disclose this information and they might not also want it in their record. So you would need to ask them, but that sort of comes around on the safeguarding side of things. You've got your help for patients with criminal records. There's also the further education. We can see if they're attending school or college, what they go to, any schooling problems. Are they on free school meals? Do they have any days absent from school or work due to health inequalities, asthma, and can't remember what the other one is. Asthma and I don't know without looking at it. Is there any emotional distress? Are they special educational needs? And then if you just go down again, yeah, sorry, you've done it, Amelia, sorry. Are they being recruited to sell drugs? And we've got links underneath there to the Gang Community Tackle Service and Time for People in Leeds, Young People in Leeds. And if you go right to the top, Amelia, please. And you can see there's web links as well. What takes you to useful web links around what this page relates to. And then the work and employment tab.
I'm not going to click on any links because it might just slow us all down. So
yeah, it probably will. Yeah. So you can record if the patient's employed, if the work's regular or uncertain, if they've got any fit notes outstanding. You can see there on that view there when a fit note was recorded. Any epilepsy or asthma, and if they've been bullied at work, because this does obviously affect people going to work. And then if you just go down to the bottom, yeah, sorry, go down to the bottom, and then you can see around employment help and support there. So you've got Mind, you've got Inclusive Growth Lead, you've got ACAS as well, the welfare rights, employment support. So it's just really a repository for you to be able to give the patient somewhere to some information and signpost them. Then we've got financial and community welfare. I will have to be careful of how long I'm taking. And again, I won't go through all that, but it basically relates to everything around the financial and social side of things. The housing, which Lisa talked about, sorry, the housing tab, Amelia.
All right, yeah, sorry, I'm trying to move my little screen down. There we go.
Thank you. So the housing tab, so this has been, you know, a really big breakthrough for us. If you just scroll down a tad, there is that letter to housing that Lisa was referring to. So a patient no longer needs to book an appointment with the doctor to basically what was going on in the past. Patient would make an appointment, see the doctor. The doctor would then take the time, spending 10 minutes talking about the housing needs, and then write a letter to housing. When a patient rings up, they can just be printed off by care navigators or reception or secretary, anybody. The only thing we sort of say is just check through with the patient when they come down to reception to pick this up, that they're happy with everything that's in there. It's mainly just long-term conditions that are in there anyway, but because they're going to be taking it to housing, we just want to make sure that they're happy with everything. And then there's the resources.
Oh, did you want me to pull it up? Sorry, right.
No, you don't need to. You don't need to. Yeah, resources page, which it sort of goes on about all the help and support there. Core 20+5, and that's that for this one. So that's the adult template or repository. And did you see the child one, Amelia?
I don't know what I'm looking for. A child. There we go.
That's it, yeah. So it's exactly the same layout. You've got all the same questions about your housing and your social needs and the healthy standards of living. And then it just basically goes children aged 0 to 5 years, and then questions what relates to their age group, and age 5 to 18, the same again. You can see there if they're exposed to smoke and things and what sort of environment they're living in, if they've got any wheezes and that sort of thing. And then the financial and community and housing is just the same as what is on the 5 to 18s. And then the resources tab, again, relates to the 20 core plus 5 and some links around their age group. And it's the same in EMIS. So in EMIS, it isn't split into two. It's all on one, and we don't have on each page the same questions because it would be too clunky in EMIS. So it is all just in one straight template. Okay, I hope I've done that really quick because I know we're sort of running over time. Has anybody got any questions?
No. Right, thanks, Lisa and Cathy. Very impressive.
Okay, thank you. But we do need, I'll just say we do need to start using it so we can start getting that information out, you know, for the communities. We can start building well, I have built some reports, but we can build on the reports and try and get some information out around the health inequalities, because it is all about the future to try and stop patients, you know, they're going to live a healthier life, they will stop coming to the GPs as much.
Okay. So next on the agenda, we've got Richard and Martel on data sharing agreement.
Yeah, hi, lovely to be with you. And Cathy and Lisa, that was absolutely brilliant. So I've got one slide. I'm just going to put it on screen. It just helpful, as a reference to talk to. So I'll just share that. So I'm going to talk to you about data sharing. This is specifically data sharing with general practice. You'll be aware that once a year we issue a new data sharing agreement, and we're sort of brilliantly blessed in Leeds. All of our practices for a number of years now have signed up to that, and that allows us to do some of the brilliant activity that we carry out to support our populations. So we're going to issue a new general practice data sharing agreement shortly. So we're talking about in the next month or so. What we've done this year, we've tried to, because West Yorkshire ICB covers a wider geography, it covers Bradford, Calderdale, Kirk, Leeds and Wakefield, and we've tried to just align to a single data sharing agreement, and it stops some of the challenges that suggest we could do stuff in one area but not in another. So we're trying to get everything aligned. So there'll be a single agreement. I think if you sort of recall previous years, it's been about 60 odd pages. It's much more concise. It's about 20. And then we've got annexes which we'll put on the West Yorkshire ICB website that cover some of the additional content. So what's different? There are 3 quite significant things that are different, and I want to just make sure that as a general practice community you are cited on these things, and then you have an option of saying, actually I've got some further questions about those activities. So let's go through them. The first one is something called sublicensing. So we as an ICB collect data both from all sort of healthcare activity within Leeds and West Yorkshire, so whether it's in hospitals or whether it's in adult social care or general practice, and we link it all together. So that's what we do. Quite often we hold on to those data and then we work with organisations, providers across Leeds to try and do things differently. We commission new services. We work closely with the third sector to plug some of the gaps that some of the statutory functions don't provide. And increasingly, we're finding that it's better to have those NHS bodies in the room with us when we're analysing data, when we're looking at specific need. So sublicensing allows us with the controls of the integrated care board and using the legitimate relationship with general practice, so only things that we are permitted to do that you've told us we're permitted to do. We're seeking to allow specific individuals within Leeds Teaching Hospitals, Leeds Community Healthcare and Leeds City Council to be able to analyse those data. The other one, which is a non sort of healthcare statutory body, is the University of Leeds. So I've included the University of Leeds in sublicensing, specifically when they work with us. So a number of you will recall the work we did around seismic, so looking at multiple long-term conditions in combination with mental health. So that's the kind of activity that we'd want to be able to have work in partnership with the University of Leeds to analyse. And I should say that this is the pseudonymised data, so we wouldn't allow anyone to, and nor should the ICB have access to identifiable data. And the final thing to mention on that is all data that we receive will always be will always have those people who have opted out of having their data used will observe all those requirements. So that's the first change. The second change is a while ago, I'm talking about 2 years ago, we requested to NHS England permission to be able to link non-NHS data with NHS data. So the reason we go to NHS England is they supply what we call commissioning data, so data that comes out of a hospital typically. So we refer to things like secondary use data, mental health services data and so forth. So because it comes from NHS England, we had to gain their permission to be able to link to non-NHS data. So the first thing that we're doing is we're looking at housing data that we collect from Leeds City Council. So that's specifically social housing. So we have 70,000 social houses in Leeds that many of our population live in, and it's brilliant, you know, coming off the back of the previous presentation, to be able to look at things like those wider determinants. How does lifestyle impact on someone's health and care? So the first thing we want to do is to link housing data, and what we'd like to do is, alongside the commissioning data that we receive from NHS England, is to be able to link things like housing data with data that we collect from our general practices, so that we've got that sort of fuller picture. beyond housing data, we collect in now data from children's services. There's some wider adult service functions, and then we will collect in data where there are challenges within a household. It could be risk of homelessness, could be financial insecurity because someone is struggling to pay council tax, or they're just generally struggling with their own finances. So that's the second change. It's permission to link your data with other data that we might receive in, for example, from Leeds City Council. And the final one is to support research. So we carry out a certain amount of activity that is almost borderline research. So we call it service improvement or service evaluation. And quite often we get challenged, certainly by NHS England, to ask us, are we stepping over the line? Because we have to share with them the purpose for which we're analysing data. So the work with the University of Leeds is a good example of that. So we embarked on a seismic program with them, which, as I say, looked at multiple health long-term conditions in combination with mental health. And one of the pushbacks from NHS England is that this is kind of research, and should we be doing that? So we've added in an item to our agreement with NHS England, but equally with our agreement with yourselves, General Practice, to support research, but only specific to research that has a direct and very tangible impact in Leeds. So it wouldn't be that we'd entertain a study that looks at things that might relate to another part of the UK, which might include Leeds, but it would be non-specific. So we're talking about specific research projects that we can point at and say this is the impact or the positive impact that it will provide to Leeds. So that's what we're seeking to do. Those are the changes. Aside from that, everything apart from the template, the format is the same. But I really, just in advance of issuing any agreement, we just wanted to bring it to your attention, have that discussion if we need to, and just make sure that what we're seeking to do is understandable. So I'll stop sharing if that's okay now, and just see if there are any questions.
No questions, I don't think, Richard. So thanks very much for that.
Brilliant. There'll be plenty of time to either come back to Martel or myself, just to and we're really comfortable just to work with you if there are any challenges.
Okay, next on the agenda we've got NHSE, Sammy.
Thank you. Hi everyone, my name's Sammy Wilson. I work in the North Eastern Yorkshire NHS England regional team with a specific focus on digital primary care. So I support our 4 ICBs with the digital primary care agenda, work really closely with the national digital primary care teams. Suman got in touch just to say that there'd been some requests from this group around, can we have some NHS England representatives come and talk to us about some of the new apps that are available? And I don't have any updates, but what I wanted to do was just come to this group, introduce myself, and just get a feel for what it is exactly you are after. If there's anything in particular that you'd like updates on or around, and I can make sure that we seek out the right product specialists to come and be able to answer your questions. Equally, if there's any sort of questions you have for me, I can attempt to answer them. And if I don't know, I can take it away and report back. So it was really just an intro and just to find out a little bit more about where your interests lie and what you'd like to hear from. Hi.
I suppose for me, Sammy, it's kind of an overview of what apps are out there which are approved,
Okay.
which are not approved. There's a lot of companies approaching practices with various bits of kit and apps.
But yeah.
And I think practices get a bit confused about what's allowable, what's not, and what's governance, etc.
Okay, that's super helpful. So I think on that basis, what I might do, Guy, is ask for some colleagues within the National Commercial and Procurement Hub to come along to talk about the governance and frameworks that are in place that would mean an app would be approved or not approved, and kind of be able to signpost this group to the various resources, if that sounds like that would be helpful.
Yeah, I think that'd be great. Thanks, Samia.
Well, yeah, I will do that. So I saw a hand go up and then down. Is there anything else? Nicola?
Yeah, sorry, it was me that was popping my hand up and then putting it down, because I think Guy pretty much covered it in.
Okay.
It's just that we're seeing, from a practice point of view, I'm hearing other regions are going live with certain applications like Copilot, Azure, and they're things that we're still not able to use. And it just feels a bit sort of deflating, really, because it could assist us with an awful lot of admin work, rather than at this moment in time waiting for a third-party package it's coming out next year that will already be approved, but we've already got these things on as dashboards.
Yeah, no, that's brilliant. And I think there's just let me have a think about the best way, because I think that'll be probably a joint ICB and NHSE response in terms of that, specifically because of the elements of sort of clinical safety requirements and testing that's required prior to going live and the resource that's available around it. So really helpful to have that specific example. Let me do a bit of digging and I can make sure we get the right people on the call next time to come back to you guys on it.
Sorry, if I could just carry on that bit though. If you go to any of the, like I went to the NHS Expo conference, you've got the big players, you've got Google there, you've got Microsoft, and what they're all saying to anybody who goes up to their stands is this has already been approved. If you go to, it's already protected, it's got the shield, it's NHS protected. But then as soon as you go back to your own practices and you're asking your own GPIT, or can we have access to this? They showed me how to do it. It's then a no. So it feels like Microsoft are saying one thing and NHS are possibly saying another.
Yes, which is utterly frustrating, I'm sure, at practice level. So yeah, really helpful to have that clarity, and I will make sure we come back with the right people. Mark, do you want to come in? You're just on mute, Mark.
All right. Yeah, I'll give Nicola a shout after this and pick some things up then. Yeah, get a bit of a grounding on that. Yeah.
Guys, is that a new handle?
Yeah, I think one specific, Sam, is on AI and large language models, ChatGPT, etc. So quite a few apps are incorporating AI.
Yeah.
And suggesting patient data uploaded to various bits of AI kit. And I think the governance, from my perspective, is quite murky on that. So I don't think there's a national framework and national guidance on the use of AI with patient data.
Yeah, absolutely. And it's something that's, unfortunately, I don't think we're evolving at the pace the technology is evolving, in terms of providing clarity around that governance. So it's something that our ICB colleagues are flagging regularly with us, that it's very much on their agenda. And I think there's an awareness that we want to do something, we can see the benefits, but we want to make sure we're doing it safely and properly within the guidance, and that actually the guidance needs to be refined to reflect kind of what would be required from smaller organisations introducing new technologies such as AI. So what I think I'll try and do around that is we have a national digital primary care AI lead, so we can talk to you about nationally what's happening and what might be available and potential guidance around that. But I think what we need to do is do it in conjunction with the ICB representatives to understand what their take is, what the ICB stance is, and what they're required to do in order to roll something like this out. And because it is complex landscape, there is significant work involved, and we do know that the ICB colleagues, are very stretched and that don't necessarily have or are equipped with the capacity in order to do that. So I don't want to give kind of an NHSE perspective. So I'll look to link in with colleagues and come back to this group around that. Mark, were you going to come in there? I saw your hand up, lit up.
I was just going to agree on the timeline, really. So I attended there was quite a large meeting yesterday, and MHRA attendance was there, the National Policy Office. And I think the speed at which we're moving in primary care doesn't match the speed at which we're moving from a cabinet and the central level. So at the moment, we have got quite a bit of stuff to put in place. We have got checklists and signposting for guidance and legislation, which we can offer out. It's there, it's available. I think really that at the moment is what we've got until something comes more solid from a central point, but I think that is still a fair way off. We have got the guidance around ambient voice technology, but everything that we're looking at the moment is not AVT. There's all the different strains of AI out there, and we can't really manage, and that's the message that we're sending back. We can't really try to manage all the different strains of AI with a policy that's written for one particular method of AI, which is voice to text. So we've brought that up on many occasions, and we hear what people are saying. It is frustrating, but we have got quite a good stopgap at the moment. So I've dropped the AI mailbox in. If anyone wants to talk or discuss it, if you want to give me a shout, more than happy to spend 10-15 minutes going over what we've got. We have progressed an awful lot, I think, locally and regionally since we started to back end of Christmas last year. Worked through January, it were a bit Wild West, but things are now smoke starting to clear a little bit. We've got a little bit more vision into the future.
Fantastic, thank you, Mark. So Mark, it might be that if I can get a national representative on to talk about nationally what's happening, we can link in the ICB specific stuff, because I do know, yourself and other West Yorkshire ICB colleagues that have done a lot of work in this space and are trying to navigate what is a really difficult and complex environment at the moment. Yeah,
I suppose to add to that, there is frustration at primary care, and next month I'm presenting at a national level to the AI ambassadors about some of the challenges we've had and the pace. And I think, as Nicola says, when we go and we talk, I spend a lot of time talking to Microsoft, and when I present myself to Microsoft, I always present myself who I am, and then I say, first of all, you need to understand, I don't have an office in a hospital, I don't look after an A&E department, and I don't use Epic, because they seem to be very focused on trusts and acutes. So they will pass a lot of things. Obviously, it's all rubber stamped. But then when we start to have those discussions about primary care and how it fits in with that kind of landscape, there are a lot of gaps, and there's a lot of stuff, in fairness, that Microsoft, AWS, and a lot of the big vendors don't really look at from a primary care aspect. I'm not saying that they think that GP surgeries are hospitals, but I don't think they go into that depth, and especially when it comes to the clinical safety as well.
Yeah, absolutely.
Okay, so we're a couple of minutes over, so that's been really useful if you come back on that one. Great. So last on the agenda, we've got a live poll. Cyril.
Hi, everybody. Good afternoon. This poll really is just to gather your thoughts, hear your feedback on how to continue to make these sessions relevant and tailored to meet our existing continuing support that we need to provide as a data quality team. So I'm just going to launch the poll right now, as we've already taken a lot of time. So would appreciate if you can please respond to the questions so that we can gather feedback and continue to make these sessions best as possible.
Okay, Cyril, have you got the answers you need there?
Sorry, just checking.
I think there's 26 responses so far, Guy. So I suppose if everyone's completed it, you can then drop off and go to the system 1-1. And just for any of those that haven't yet completed, if you could please complete it, would be appreciated.
Yeah,
Thank you.
great. Yeah, thanks to all the speakers. So I'll drop off and rejoin the system on myself. So thanks to
Perfect.
everybody.
Thanks, Guy.
Okay.